Hello, I'm Pam Walters, a psychologist with the National Cancer Institute. Welcome to this session entitled New Investigations in Cognitive and Psychosocial Research for NF. And I'm going to turn this over to my co-chair, Dr. Walsh.
Hi, I'm Dr. Karen Walsh, co-chairing with Pam. It's nice to have you all here. We, in planning this session, really want to introduce a broad range of topics and speakers, some new and relevant information to both clinical and scientific, the clinical and scientific communities. And we were pleased that a lot of the topics really helped us cover topics over the lifespan. So we have presentations today on early motor development in NF1, cognitive load in children with NF1. We have a speaker on the predictors of social emotional development, adolescent transition, and adult perspective for psychosocial trials. So we are starting today with our esteemed invited speaker, Dr. Carrie Strump, PhD from the University of Kansas School of Medicine. And she'll be presenting to us today on adolescents and young adults with neurofibromatosis type 1, a descriptive study of adaptive functioning. Thank you, Carrie.
Hi, everyone. My name is Carrie Strump, and I am a licensed psychologist at the University of Kansas Health System. The research I'll be presenting on today was conducted while I was at the Pediatric Oncology branch of the National Cancer Institute. And I just want to real quickly say thank you so much to the Psychosocial group for inviting me to talk to you all today about adolescents and young adults with NF1 and plexiform neurofibromas. I have no disclosures for this talk. My objectives are to review with you all the common transition difficulties for adolescents and young adults with chronic illness, describe the current literature for adolescents and young adults with NF1, and present two studies for AYA with NF1s and plexiform neurofibromas. The first study was a descriptive study of cognitive functioning, adaptive skills, and successful transition into traditional adult roles, and this manuscript has been submitted for publication. And study two was an evaluation of transition readiness, disease knowledge, and responsibility and engagement knowledge of independent living skills, and this manuscript is currently in preparation. So adolescents and young adults with chronic illness. We know the transition from adolescence into young adulthood is a complex process, even for healthy teens. And so research has clearly identified that adolescents diagnosed with a chronic illness face more barriers and are less successful in this transition than their healthy counterparts. Challenges often include successful completion of educational goals, finding and securing steady and gainful employment, engaging in relationships, both social as well as intimate or romantic relationships, obtaining independent living or living independently, and successful transition from pediatric medical providers to adult providers. There has been some research done on AYA with NF1. The current research has shown that AYA with NF1 lack a thorough understanding of their disease or condition, which is made exponentially harder because NF1 is so different from person to person. So having that understanding of their own condition is an area that they could use some extra support. The research has highlighted that there is a lack of formal guidance specific to the NF1 population for medical transition. So more and more formal guidance is coming out for different chronic illness populations, sickle cell disease, congenital heart disease, different areas where there are a lot more patients that have these chronic illnesses. And in rare diseases like NF1, those formal guidance or formal guidelines don't tend to be as predominant or available. Patients identified in a qualitative study that they feel like NF1 has some impact on all factors of young adult life, and the patients identified concerns across the lifespan that impact different parts of their life, including pain, social functioning, physical condition, and stigma of having NF1. So the first study was looking at cognitive and adaptive functioning and how those relate to each other, as well as how they might relate to obtaining traditional adult milestones. Our goals were to provide a description of adaptive skills and level of independence among a sample of adolescents and young adults with NF1 and plexiform neurofibromas, and to evaluate the relationship between adaptive functioning and aspects of cognitive and adaptive functioning. The data for the first study were extracted from a larger natural history study. We looked for patients between the ages of 16 and 34 who had completed a comprehensive cognitive evaluation. 55 patients met criteria. And we also took a subset from this from the 55 patients of patients who were greater than 18 and who were no longer in high school, and they were included in additional analyses, and there were 34 patients who were included there. For the comprehensive cognitive evaluations, patients had some form of IQ or cognitive evaluation, academic testing, a parent report questionnaire of adaptive functioning, and as well as attention and executive functioning evaluation. So this population was 63% male. They were about 19 years old. They were predominantly white. About half reported a history of at least one psychiatric disorder, including anxiety, depression, or bipolar disorder. 49% reported having a learning disability. 37% reported having ADHD. And the disease severity was fairly evenly split between mild, moderate, and severe, and this was rated by one of our medical professionals. So the results of from the Vineland, which is a commonly used questionnaire of adaptive functioning, and in this case was a parent report questionnaire, indicated that just under half of participants scored more than one standard deviation below the mean for the daily living subscale as well as the socialization subscale. And compared to the 16%, which what we would expect based on population norms, you can see that a much higher percentage of these patients were scoring lower on adaptive skills or engaging in fewer adaptive skills. By contrast, verbal and performance IQ scores were in the average range, but with 20% and 26% scoring more than one standard deviation below the mean, respectively. And why we report the data in this way is that sometimes it can be kind of tricky because your score may be in the average range. And if you just look at that score, then you say, okay, these kids or these adolescents and young adults have the same skills as their chronic illness counterpoints, and we don't need to take into any more considerations. But if you start looking at the data in a different way, and we kind of say, well, but how many kids are struggling? And is, because the disease varies so much from child to child, may you have a child who's doing or an adolescent who's doing very well, and then that kind of cancels out the child who's having more difficulty. And so we like to look at, the greater percentages to see, who's struggling, how many kids are struggling, and in what areas, versus just taking the single mean. Here we looked at the results of the daily living and social skills subscales from the Vineland and how they related to cognitive variables as well as executive functioning and academic variables. You'll see that the daily living subscale was positively related, and this is a cross-sectional sample. So you'll see that the daily living skills were positively related to performance IQ, symbol search, which is a measure of processing speed, verbal fluency and category switching, which is a measure of executive functioning, as well as longest digit span backward, which is a measure of working memory and executive functioning. The social skills subscale was related to those variables, and in addition to verbal IQ, number letter switching, and calculation, so more significant or not related to more variables than the daily living subscale. Within that subgroup that we've extracted from the larger data set of patients who were 18 or greater than 18 and had graduated from high school, we had 34 patients. The mean age of this group was about 20. 47% of this group were enrolled in some sort of post-secondary education, so part-time college, full-time college, or trade school. 29% of them were working either full-time or part-time, and of those 6 working part-time, 4 were also in that previous group who were enrolled in school. 35% were neither employed nor in school, and this next number is, I think, very impactful. So almost 62% lived at home with their parents, compared to 34% of the greater U.S. young adult population. So almost twice as many kids young adults with NF1 were living at home with their parents still versus their healthy counterparts. And for this group, all patients completed 2 comprehensive evaluations 3 years apart, because we were hoping to look at some potential longitudinal predictors. So we created 2 groups based on obtaining adult kind of traditional adult roles, and these 2 groups were created for the logistic regression analysis. They were created or made up of patients who were either employed or in school, so had attained those traditional adult roles, or were unemployed or not in school. The ability of the daily living and socialization scores to predict group membership in a cross-sectional sample neared but did not reach statistical significance at with P's of 0.08 and 0.07 respectively. When verbal and performance IQ scores were included in the model as a predictor variables, verbal IQ significantly predicted group membership at P equals 0.04. Specifically, for every increase unit of change in verbal IQ, the odds of being employed or in school increased by 7%. This model was no longer significant in a longitudinal model evaluating VIQ and PIQ at baseline could predict group membership 3 years later, how it was very close or very near statistical significance at P equals 0.05. And of course, it's important to note that this was a very small sample size of 34 patients. So hopefully, if we are able to get a larger number as this natural history study goes on, we may be able to find some predictor variables that would help identify areas to intervene. So based on the concerns identified in study 1, we took a deeper look into the transition readiness of AOIA with NF1 and plexiform neurofibromas. We used 2 commonly used measures for AOIA transition, including the UNC Transition Index, which is a standardized interview, and we adapted the scoring for patients with NF1. It's based on patients with kidney disease, and we also use the Transition Readiness Assessment Questionnaire, which is a self-report questionnaire. The following is unpublished data, and the manuscript is currently in preparation. So for this study, the data was collected from 2017 to 2019 as part of a larger natural history longitudinal study. Patients between the ages of 16 and 34 who had appointments during this time were invited to complete the study measures, and the transition interview was administered by a licensed psychologist or a psychology associate. 43 participants agreed to participate. We excluded 3 due to incomplete administration of study measures, which resulted in a sample of 40. They were evenly split between female and male participants. 77% were white. The age range was 16 to 28, again with a mean age of about 20. So given that it's fairly new to meet with and talk with patients with AYA and NF1, I wanted to talk real quickly about just some of the successes and barriers that we had conducting this study. I'm happy to report that all patients who were approached agreed to participate, so everybody seemed willing to talk about the subject of transition. And anecdotally, the many parents of younger patients expressed an interest in discussing these topics with us, and we're seeking guidance on how to address transition issues. One of the barriers that I experienced was that questionnaires were heavily weighted on medication management and adherence, which really made large portions of the questionnaires not applicable to this patient population. They all had the option to say that it wasn't necessary for their care, but it definitely decreased the number of questions that were applicable for these patients, which could be a barrier, although, as everyone knows, that it might be a current barrier. With the introduction of MEK inhibitors, this may become less problematic in the evaluation of medication adherence and may become a much more important component of the AYA transition for patients with NF1. So for the Transition Readiness Assessment Questionnaire, it evaluates 2 domains: the skills for chronic condition self-management. Again, this is the one that was highly focused on prescriptions and medical equipment, with 9 out of 16 questions focused on this, as well as the second subscale, which is skills for self-advocacy and healthcare utilization. The response options were scored from 1 to 5, include: no, I do not know how to do that; no, I do not know how, but I want to learn how; no, I don't do this, but I'm learning how to do this; yes, I have started doing this; and then a 5 would be yes, I always do this when needed. Interestingly, I had to actually contact the developers of the questionnaire because there was an answer that patients were frequently giving me that didn't fit anywhere on the response options. So patients would say, well, yes, I know how to do that, but I don't do it, or I choose not to, or my parents still do it for me. And that doesn't fit anywhere in here because they are saying that they do know how to do it, they just choose not to. And ultimately, in consultation with the developers, we decided that that would be a no, but I am learning how to do this. So not kind of giving them credit because they're not doing it, but indicating that they are close to doing it, or at least know how. Patients could also select not needed for my care if the question. The preliminary results from the Transition Readiness Assessment Questionnaire come from the two subscales. The first subscale, the Skills for Chronic Condition Management, the average score ranged from 1.6 to 5, and the mean score of all patients was 3.6. And so a 3.6 would fall somewhere between no, I am not, but I am learning how to do this, and yes, I do this sometimes. So basically they're falling somewhere between no and yes, so moving towards doing things more independently, but your average 20-year-old isn't necessarily doing the things that they need to do even some of the times. As you might expect, the results were positively correlated with age. So as somebody got older, they had more knowledge or skills or engaged in taking care of their chronic condition more. The second subscale, the Skills for Self-Advocacy and Healthcare Utilization, the subscale scores ranged from 1.8 to 4.1 with a mean score of 3.3. So again, a little bit closer to that no, but I'm learning how to do this versus closer to the yes, I'm doing that sometimes. And interestingly, this score was not correlated with age, although the significance level was, or the p-value was approaching significance. So what aren't they doing? Here below you can see a table for patients, the percentage of patients that responded or endorsed a no answer, so either a 1, a 2, or a 3. Nearly 70% of the population said that the patient population said that they had or had not or would not apply for insurance if their own insurance expired. Almost 60% said that they did not pay for their own medication, nor did they have very in-depth knowledge of what their insurance covers. Also, they didn't engage in following up on referrals, tests, or labs, or make a list of questions before attending a doctor's visit. And then we're getting down to those things that are kind of more medical management or management of their responsibilities, like making appointments or filling prescriptions, and then things like using community support or calling the doctor about health concerns. For the UNC Transition Index, this is a 32-item structured interview questionnaire, and it has 10 different domains. Responses were recorded and scored using the standardized scoring rubric. Scoring definitions were adapted for NF1 from chronic kidney disease. Scores ranged from a 0, which means does not know or does not have an idea of the answer to the question. A 0.5 is has an idea or has some understanding, and a 1 knows definitely. So an example for the question, what is the name of your health condition? If somebody says they have NF1, neurofibromatosis 1, or neurofibromatosis, and or they say they have a genetic disorder that causes tumors to grow on nerves, that would be a score of a 1. If they said if they give a general answer like I have tumors or I have cafe au lait spots on my skin, they would be given a 0.5 for knows a little bit about their condition. And then if they don't know the name of their condition or anything about their condition, they would receive a 0. All applicable answers were summed and divided by the number of answered questions. So this is an example of the scoring rubric and the different questions that might come on the type of health condition section. The subscales were summed, resulting in a total score, which ranges from 0 to 10. So in our preliminary results of the transition interview, you can see that there are several areas where the mean score falls in the lower range to indicate areas where patients are less knowledgeable or less engaged in these transition skills. Nutrition being one of the most important ones, although this one is one that didn't transfer very easily from kidney disease to NF1, simply because there are not a lot of dietary or nutrition recommendations for patients with NF1. So this was related to eating healthy. Self-management skills, knowledge of insurance or understanding of how their insurance works, as well as understanding how to transition to a new healthcare provider. So these are all lower areas of that where our patients scored, areas where our patients scored lower. So areas of weakness within those subscales that I just identified were making healthy food choices, calling in their own prescription refills, picking up their prescriptions, calling or contacting the doctor with questions, making their own doctor's appointments, knowledge about their health insurance. In many of these areas, lower scores, according to the scoring rubric, many of these areas, lower scores indicate that that parents are still completing some or all of these tasks. And so this may be indicative of the fact that parents are not transitioning those skills, or adolescents are not expressing interest in transitioning and taking over these skills, which is definitely an area that the medical teams can intervene and help support and scaffold these families. So the total score for patients with NF1 was 6.49, and it was positively correlated with age. So as patients got older, they had more transition skills, or were engaging in more self-care, taking care of their own medical needs. So the limitations of the study, both studies had relatively small sample sizes, but were not unreasonable given that NF1 is a rare disease, particularly when you focus on patients with plexiform neurofibromas. The generalizability may be a little bit limited to the wider NF1 and AYA population, as patients have PNF tumors, which only occur in about half of patients with NF1. And these are also patients who are willing to travel and engage in a longitudinal research study, so maybe more motivated or maybe have more resources. For study 2, adaptations were made to the UNC Transition Index to increase the applicability to patients with NF1, which may limit the ability to compare the published data to other chronic illness populations. So what are my take-home messages? Similar to other chronic illness populations, AYA with NF1 and PNFs are exhibiting difficulty with transition in several areas, including medical care and responsibility, attainment of traditional milestones of adulthood, including independent living, post-high school education, and part or full-time employment. Formal transition programs and guidelines should be created to help medical teams provide targeted guidance for this population. It will be important to address both patient engagement in transition, but also parent willingness to encourage independence. And important areas to consider specific to NF1 would be knowledge, helping families understand and be aware of any cognitive or academic limitations, as well as helping AYA and families identify vocational or social support services they may qualify for as adults. Thank you so much to everybody on this slide, and I welcome any questions from the group now.
Thank you so much, Carrie. That's an excellent set of projects, I should say. And I'll just make one comment, and then there are a few questions from the audience. So, I mean, what you highlight here is actually what was talked about a little bit in the clinical care session yesterday about how we need to be, as clinicians, starting to think about talking about transition much earlier than maybe we think we should, in terms of, as we get into later adolescence, we need to be starting those conversations much earlier. And educating kids about their diseases much earlier. So I'll leave it at that brief comment.
Yeah, absolutely. So generally, when you look at AYA transition recommendations, they usually start at ages 12 to 13. And that's when they recommend starting to meet with kids, even individually for part of the session, and talking about those transition and kind of encouraging some independence and making their healthcare decisions. So it is a lot younger than we ever would think about.
Yes, true. So I want to get to a couple questions here. We have 2 questions from one of our attendees. One was, do you know if any of your 55 subjects, I think this was from the first study, had autism or a possible autism diagnosis or traits?
Autism, I'm sorry, I'm trying to think if it was an exclusionary criteria. The participants in our study did not have autism.
Okay. Great. And then the same attendee has a question. In your opinion, do you feel that the extent of psychiatric and neurodevelopmental comorbidities in NF patients is underreported and underevaluated?
I think it's probably underevaluated for sure, mostly because there isn't, in my experience, a targeted department that follows these kids. So, it might be genetics at one hospital, or it might be neurology at another hospital, or it may just be a primary care physician who is knowledgeable about it. And so I don't think that there is always the focus on evaluating those things unless there becomes a significant problem. And so it tends to be more problem focused. I think any guidance about helping AYA transition would include early evaluation for cognitive difficulties, and then monitoring over the course of their young adolescence and young adulthood to make sure that there isn't anything that is becoming more problematic. So I do think, at least clinically, it's probably underreported or under evaluated just because of access to those services.
Great. I just want to throw one more quick question, then I think we need to move on. And I'm going to miss a couple questions, sorry to the audience, but have you identified any training curriculum? Is there anything that you know of that can address some of these, adaptive weaknesses or issues that you brought up that you're seeing in these kids?
Not specific to NF1. I think there are a lot of resources out there about ways to help with focusing on those adaptive skills. And you would have to look to other literature, like maybe literature for individuals with learning disabilities, and how can we help them be more functional and engage in those adult transition, or individuals with ADHD. So I think we look to, I don't think there's anything for NF1, but I think if you look to the issues, like the underlying issues that are contributing or potentially contributing to the difficulty with attaining those adaptive skills, there's lots of research out there and lots of programs available to help with that.
Well, there's a couple other questions, but I'll move on here and let Pam introduce our next speaker. Thank you so much, Carrie.
No problem. Thank you, everyone.
Yeah, thank you. I want to also say great talk and a lot of new information. So thanks for presenting that. Our next speaker is Sarah Parday. She is a graduate student in the Doctor of Clinical Psychology program at the University of Wisconsin-Milwaukee. And her the title of her talk is Motor Development in Early Childhood, an investigation with young children with NF1. Go ahead, Sarah.
Today I'm going to be talking about a longitudinal examination of motor functioning in young children with neurofibromatosis type 1. Research support comes from a variety of sources, including several NF foundations. Our collaborators on this project were from the Children's Hospital of Wisconsin and the University of Chicago. We do not have any financial disclosures or conflicts of interest with the information in this presentation. The literature demonstrates rather consistently that weaknesses in fine and gross motor functioning are evident for children with neurofibromatosis type 1. There's also evidence that these challenges persist into adulthood. Children with NF1 are vulnerable to weaknesses in balance and upper limb coordination, sensory motor skills, strength and agility, problems with visual spatial skills, and visual motor integration. Although there is considerable evidence of motor difficulties in the school-age period, there is sparse literature describing the extent of motor challenges in early childhood in NF1. This is significant as motor abilities affect functioning across a multitude of contexts, including exploration of environments, playing, and pre-writing skills.
So let's take a brief look at what we do know about motor abilities in the early childhood period in NF1. Lorenzo and colleagues found that toddlers with NF1 have significantly poorer motor development than age-matched controls. In one of our previous studies with a sample that overlaps with the present study, we found that young children with NF1 had challenges with both mildly challenging, in this case NEPSI imitating hand positions and visual motor precision, and complex fine motor tasks, in this case the DOS-2 copying subtest, compared to both normative data and to a control group of unaffected siblings. So to summarize, children with NF1 seem to have more difficulty than control groups on motor tasks from a young age. However, at this point, there are no data demonstrating the trajectory of motor abilities over time, so we don't know whether children with NF1 already have motor difficulties that persist into later childhood, or whether they are able to catch up to their unaffected counterparts. Thus, the goal of the present study was to analyze the pattern of motor development in a sample of young children with NF1 across the early childhood period in comparison to their unaffected siblings. Let's look at all the participants in the sample. Participants were enrolled between ages 3 to 8, and the aim was to assess them yearly until they were 8 years old. All of the children in the NF1 sample had a confirmed clinical diagnosis of NF1. All available time points were used in our analyses. Inclusion and exclusion criteria listed here on the slide. We had one caregiver participate consistently across the study period, and demographic information is displayed on the table here.
Our participants were recruited through local neurofibromatosis clinics in NF Midwest. The findings from the present study are from a broader longitudinal behavioral phenotyping study. At each study appointment, participants were administered a 4-hour age-appropriate neuropsychological battery, including measures from a variety of domains. For the purposes of this talk, we will only describe those measures which were utilized for longitudinal motor functioning analyses. So first we use the Scales of Independent Behavior Revised, or the SIBAR, which is a caregiver interview that examines motor, social interaction and communication, personal living, and community living skills. We use the gross motor and fine motor subscales, both of which include 19 items. The gross motor scale assesses balance, coordination, strength, and endurance, while the fine motor scale assesses precise movements and hand-eye coordination using small muscles. Each item is rated on a 4-point scale, from 0, meaning never or rarely does the task without help, to 3 does the task very well without help. We also use the Differential Ability Scale's second edition early years, or DOS-2 early years, which is a performance-based measure of various cognitive abilities. From the DOS-2, we used the copying subtest, which assesses fine motor coordination and visuospatial skills. It is a paper-pencil test during which the child copies line drawings of increasing complexity. Data were analyzed using RStudio, using LME and LME4 packages for linear mixed model analyses. We corrected using the false discovery rate, or FDR method, so a correction at Q less than 0.05 was considered significant. As fixed effects, we included precise age and NF1 status, meaning whether the child was in the NF1 or the unaffected sibling group, and participant ID was added as a random effect. We used the restricted maximum likelihood approach. Each model used raw scores, and the data were centered around the overall mean raw score of each measure. Trajectories of the NF1 and unaffected sibling groups were statistically compared. For context, growth curve analyses flexibly account for missing data and inconsistent spacing between time points. So the statistical method allows for analysis of overall trends in the development of motor functioning through the early childhood period. We first wanted to analyze whether there are any significant relations between demographic variables and our variables of interest. For our NF1 sample, socioeconomic status using the Hollingshead Index, NF1 etiology, and sex were each not significantly related to any of the motor functioning variables. For unaffected sibling participants, paradoxically, socioeconomic status was negatively correlated with the DOS-2 copying T-score. I'll now briefly describe our attrition findings. No significant differences were found on most study variables listed here on this slide between participants with one visit and those with more than one visit. However, for both children with NF1 and unaffected siblings, SIBAR fine motor raw scores were significantly lower for those who returned for subsequent visits than those who did not return. Additionally, only for unaffected siblings, SIBAR gross motor raw scores were significantly lower for those who returned for subsequent visits than those who did not return. All right, so now let's look at the results of the growth curve analyses. For each model, you'll notice that both the NF1 and unaffected sibling groups demonstrated gains in their relative abilities over the early childhood period. Let's start with fine motor scores. So here you will see that there's a significant age by NF1 status interaction, meaning that those scores were impacted when factoring in both age and whether the child has NF1 or not. And the lowest lines depicted here in the upper left-hand corner of the SIBAR fine motor raw scores depict a growing gap in functioning with increasing age between the NF1 and unaffected sibling group. For gross motor raw scores, there was a significant effect of NF1 status, meaning that those scores differed based on whether or not the child had NF1, as well as an age by NF1 status interaction effect. Similar to what we saw for the fine motor scale, the lowest lines of the SIBAR gross motor raw scores depict a growing gap over time between children with NF1 and their unaffected siblings.
For DOS-2 copying scores, there is a significant effect of NF1 status on performance. The lowest lines of the DOS-2 copying ability scores demonstrate consistently poor performance in the NF1 group in comparison to unaffected siblings across time. When we look at all of the findings, we see that although the patterns of development appear different across motor abilities, in each case, children with NF1 have weaker motor functioning than their unaffected siblings in the early childhood period, and that motor difficulties persist or grow over the course of early childhood. So what can we do with this information? Our findings suggest that motor difficulties for children with NF1 in comparison to their unaffected siblings begin early in life and continue at least through the early childhood period, though there are slightly different patterns and emergence of difficulties for different indicators of functioning. As we saw depicted in the lowest lines, by 5 to 6 years, a gap in some motor abilities begins to develop between children with NF1 and their unaffected siblings. Specifically, difficulties in comparison to unaffected siblings on performance-based tasks may be evident as early as 4 years old, gross motor challenges based on caregiver report by 5.5 years, and fine motor difficulties are evident to caregivers by about 6.5 years. Since difficulties were present based on both caregiver report and performance-based measures, both modalities may be appropriate tools for assessing these difficulties in this developmental period. The study was limited by a small sample. Another limitation of the present studies that are designed do not include traditional physical and occupational therapy clinical measures of fine and gross motor development, like grip strength or gait. However, caregiver report and performance-based measures, often used clinically in psychological settings, are related to these measures. This study also did not include any blinding procedures for test administrators of the DOS-2, and there are no specific strategies to minimize caregiver bias in their reports on the CIVR. We recommend focused assessments or screenings of motor abilities early in life for children with NF1. Early intervention is also recommended for fine motor, gross motor, and visual spatial skills at least as early as 5 to 6 years of age, given that the gap in some motor ability seems to be growing between children with NF1 and their unaffected siblings in this time period. Because there are no published data using imaging techniques longitudinally in children this young with NF1, we must look to the unaffected literature for considerations of the mechanisms underlying this gap. We know that beginning at 5 years old, children's brains begin to expand in the prefrontal cortex at a rate of about 1 millimeter per year, which typically coincides with the identification of more subtle motor functioning challenges. The prefrontal cortex is an integral component of different aspects of motor ability, so it could be the case that it is at this developmental juncture that children with NF1 and their unaffected siblings have differing neurodevelopmental patterns, which may lead to observable difficulties on everyday caregiver report and performance-based ratings. It is possible that challenges could be identified even earlier, but the study did not include children younger than 3. In terms of interventions, there are no well-validated treatments for poor motor functioning specific to NF1 at this point. Generally, though, young children benefit from individual therapies like occupational therapy or physiotherapy that is tailored to the specific motor deficit or delay identified in the child.
We'd like to thank all the families of the children with NF1 that participated in this work, and we would also like to thank all of the genetic counselors and our collaborators. This research would also not be possible without all the former and current graduate students in the lab, as well as many, many undergraduate research assistants. So take some time for questions now. Thank you.
Great, wonderful talk, Sarah. Thank you so much. And it's really nice to see some longitudinal data where you can really begin to determine where those gaps start. It's really important. There aren't any questions right now. I was wondering.
There is one in there, Pam, but go ahead with yours first.
Sure. I was just wondering, do you think 5 to 6 years old is early enough to start interventions, or would you recommend like 0 to 3 interventions, or talking to parents about things that they might be able to do? What's your thought about that?
Yeah, well, using our data, we can't really tell because we didn't collect that information. It looks like, at least on the copying score, so those visual spatial skills, there were some differences there already from the start of our data collection period. I would say it would be definitely worth including that in an evaluation if you were working with a child with NF1 for sure. And there is some toddler data out there. I think I mentioned at the beginning that there are some differences starting to emerge there. Mm-hmm.
Yeah, I think that aligns with, the longitudinal study out of the Australian group some time ago. The motor deficits were what kind of separated the groups, the kind of typically developing children from the kids with NF. The earliest, those were the first things that differentiated. And it was, I think, really by around 2 years of age. And if I can, Pam, the one kind of comment thought, I guess, or something you can respond to, Sarah, I really like this. This actually aligns a lot with what we see in terms of the patterns of higher cognitive skills, in terms of this, widening gap and this kind of alteration maybe in the trajectory of development, or the pace of development, if you will. And I think it is interesting to document that because, in the clinical setting, certainly we have families that ask us questions about, will my kid catch up on this skill? Can I expect them, to get better and be kind of like their peers at some point? And I don't think this means an answer is no, but it means perhaps we need to be getting at some things earlier for the potential. But I think then we can also be giving families a more informed answer to that question, because I think sometimes they get that information from others that just let it go, it'll catch up eventually. But I don't know that that's the case for sure in our NF kiddos. Pam, do you see the question in the thing?
Yeah.
Or do you want me to read? Okay.
I scrolled down, I found it. So there is a question. It's asking, did the patients with NF1 have only a follow-up, or were they involved in an intervention arm to improve motor difficulties?
No, so there was no intervention associated with this study.
And did you only observe NF1 patients compared to their siblings, or did you have a kind of support? I don't know what that means, but
Did you say a kind of support?
Support, but I don't mean that means intervention.
Oh, yeah, no, there is no, they may have, of course, this is a longitudinal study and we can't control what people do throughout that time. So there may have been a couple of kids here and there, but that wasn't something that we initiated for them. It would have been a very small, like a couple of participants.
I think we have time for one last question. Should occupational assessments, occupational therapy assessments also be performed routinely at specific ages? Do you have any comment on that?
Yeah, I think that would be very helpful. I know that, the medical field is moving more towards more integrated care with different disciplines. And based on our data, I think that it would be very helpful to have an occupational therapist along the way from this young age to help track and identify those difficulties early on. Sort of like what Karen was saying, I think that this data for me was very motivating to try and find more interventions that are tailored to NF1.
Great, thank you. I think in terms of time, we should probably move on to the next one.
Okay, thank you, Pam, and thank you, Sarah. I'm very excited to introduce the next speaker because she's a student in my lab, a very bright one that's going to do some really amazing things moving forward, clearly based on her work. So our next speaker is Sarah Silber. She's at Franklin and Marshall College, and she's presenting on our study examining cognitive load in children with NF1 compared to typically developing children. I'll turn it over. Thank you.
Hi, my name is Sarah Silber with Children's National Hospital, and today I'll be talking about our project titled Examining Cognitive Load in Children with Neurofibromatosis Type 1, NF1, compared to typically developing children. For some background, cognitive load refers to the extent of working memory resources needed to complete a given task. Cognitive load theory was developed by John Swaller in 1988 and serves as a model for understanding how increasing cognitive load affects the human mind. The basic idea behind cognitive load is that increasing demand can cause cognitive overload. How learning new material works in simple terms is demonstrated in this image on the right. New information comes into sensory memory and then into working memory, where it is rehearsed like practicing a math problem and then goes into long-term memory. Swaller describes how this process can be interrupted, and he does so by breaking down cognitive load into three segments: intrinsic, extraneous, and germane load, which can be shown in the image on the left. Intrinsic load is defined as the inherent difficulty of the material itself, which can be influenced by prior knowledge of the topic. Generally, we want intrinsic load to be simplified for an individual to understand. This is the first piece of information coming in using the math problem example again, ensuring the difficulty of the problem is appropriate for the age of the student. Next, extraneous load is defined as the load generated by the way the material is presented and which does not aid learning. This would be how the material is presented to a student. Generally, we want to reduce extraneous load by teaching the material in an easy to understand manner. Finally, germane load is defined as the elements that aid information processing and contribute to the development of schemas. Schemas are ways that we break down information into categories for us to understand the material better. An example of this would be integration exercises or analogies that help students categorize new information into already present schemas. Generally, we want to maximize germane load, as this load is what helps us get information into long-term memory. In addition to these aspects, cognitive overload can occur in each. Cognitive overload is when the information learning system is interrupted because of too much or too complex information attempting to be processed. In our study, we are using cognitive load theory as the backbone for understanding the presence of cognitive overload in children with NF1 compared to non-affected children. Deficits in attention, inhibition, and working memory are all highly prevalent in children with NF1. These deficits align with overload in the intrinsic and extraneous factors of cognitive overload. For these children, susceptibility to cognitive overload can impact multiple areas of function, including learning, socialization, and adaptive skills. This overload is secondary to disruptions along the processing pathway that can result in a lack of adequate encoding and rehearsal information. Our study is a prospective collaborative study with the primary aim of understanding and describing the presence of cognitive overload in children with NF1 compared to non-affected children. For our methods in the primary outcomes, we use the tasks of executive control, or the TEC, for testing. This image here walks us through the tasks. The TEC includes 3 levels of working memory demands: 0 back, 1 back, and 2 back, crossed with absence versus presence of inhibitory signal. The participants completed the tasks on a laptop with 2 keys, a blue key and a red key. The blue key was for standard response and the red key was for a target response. To explain what this means, let's go through this first row of this image. This row is for the 0 back non-inhibitory task. In this task, the participant was instructed to press the red key each time that they saw the butterfly, the target item, and the blue key for all other items, the standard. This next row shows a 0 back inhibitory task. Here, the participant was instructed to do the same thing as the first task, press the red key for the butterfly and blue for all other items, but this time do nothing if the object was in its own box, which was the inhibitory aspect. The third row shows a 1 back non-inhibitory task. Here, participants were told to press the blue button for all items, except if the item appeared twice. If the item appeared twice in a row, the second item meant to press the red button, which was the target. The fourth row shows the 1 back inhibitory tasks, with adds on the same task of inhibition using the box as in row 2. The last 2 rows show the same tasks, but with 2 back tasks. For our study, only 0 back and 1 back were considered for analysis. For analysis, alpha was set to 0.05 and general linear models were applied to evaluate between NF1 versus control and within group task load differences. For our design and methodology, we had a total of 54 participants, including 27 children diagnosed with NF1 and 27 age and sex matched, typically developing controls, all with ages ranging from 7 to 15 years old, with a mean age of 10.7 years and a standard deviation of 3.35 years. Our results showed that children with NF1 showed significantly greater problems on task performance than normative children, even before adding cognitive load. Results indicate no significant differences between the NF1 and control groups on standard or target response accuracy when the task required inhibition alone on 0 back. When considering only working memory load 0 back versus 1 back, there was no significant difference between groups on target response accuracy. However, there was a significant difference between groups on the standard response accuracy based on working memory load alone. On the combined load task, which was inhibition and working memory, there were no significant differences between groups for either target or standard response accuracy. You can see the statistical values in this table on the slide. Now we will move on to further discussing our findings on response accuracy. Let me orient you to the graphs of our results. The y-axis of both of these graphs represent the t-scores. An important note to make is that the higher the t-score, the worse the performance is. The x-axis shows the differences in working memory load, which is the 0 back versus 1 back tasks that were previously mentioned. The left graph shows results for only working memory load, and the right graph shows results for additional working memory load plus inhibition. In this left graph, there is no inhibition and only working memory load tasks. The red lines represent the target response, and the blue lines represent the standard response. Solid lines represent NF1 children, or children with NF1, and normative children. Dotted lines are for normative children. As you can see, children with NF1 had higher t-scores for both standard and target responses compared to controls. They also perform worse on the standard response as working memory load increases, but stay relatively stable for the target response. Normative children also stay relatively stable with the target response, but perform better on the standard response when working memory load is increased. The right graph shows inhibition added to additional working memory load. Children with NF1 perform significantly worse on the standard response when both inhibition and working memory demands were included in the task. From this graph, we can see that when the task included both working memory and inhibitory demands, children with NF1 performed worse on standard responses and better on target responses. In other words, children with NF1 sacrificed the standard mundane responses in favor of the target responses, perhaps because they believed that the target responses were quote unquote more important. This pattern of sacrificing the standard responses in favor of target responses is not present in the control group. To conclude, children with NF1 appear to be susceptible to an increase in working memory load in particular, resulting in poorer response accuracy compared to typically developing peers. In addition, when cognitive load is increased, children with NF1 tend to sacrifice the mundane or background standard or blue task responses in favor of the target or the red task responses. This suggests a specific problem with managing cognitive load and allocating adequate cognitive resources and performing at expected levels under such conditions. Finally, working memory demand in particular may be the source of cognitive overload, intrinsic and germane, in children with NF1, while inhibition does not appear to result in additional overload. Our next steps with this project are to examine the impact of additional cognitive overload, for example, the two-back, in associations with everyday functional impairments. Thank you for listening.
Thank you so much, Sarah. Obviously, I'm a little biased about the project, but what I thought about, I guess I have a couple quick comments. I don't see any questions right now, but feel free to enter them, please, if you have them. One comment was really just as we think about how this applies to children in their everyday life, we're thinking about because these kids with NF1 don't seem to be able to have enough cognitive resource to deal with both aspects of the task. What you're saying is that they prioritize one aspect because they can only really handle essentially one aspect. So they are, again, our sort of maybe working hypothesis is that they have deemed one aspect more important than the other. That still has significance in a classroom setting, right? If a child's working at a desk and the teacher is saying some important information in the background, when you suffer from cognitive overload, you're going to miss that background piece that sometimes is actually quite vital to you being successful in the classroom. So just that comment for, to sort of say a little bit more. And the other thing I thought about that related to Carrie's work was it would be interesting to dig into the cognitive aspect of these adaptive limitations, maybe at this level of, cognitive overload. And, to me, it seems like those adaptive weaknesses could come from many sources, whether it's, we see in a lot of different medical conditions, a lack of opportunity is sometimes why there are, weaknesses in developing adaptive skills, maybe some overprotection at times for some families of not being ready to let their kids try certain things. But then I think there certainly could be these individual characteristics of, maybe it's very, I think parents get overloaded with trying to make medical appointments, refill prescriptions, et cetera. So how much of what we're seeing in the kids' adaptive development is related also to this overload with the task itself. So I guess that's not a question, but something interesting we can kind of focus on in the future.
And we do have some questions that popped up.
Oh, okay.
You want to?
Oh, thank you. Okay, so so the question is, what percentage of patients are affected by cognitive overload? Sarah, I don't know if you have that accessible to you at the moment.
I do not know that I do.
Okay, yeah, I don't think we have that in there. And honestly, I don't remember it off the top of my head either. I'm sorry, anonymous question asker. But we do have another question too. Are there any particular interventions that come to mind to help overcome the overload of working memory?
So we didn't really touch on that in the study very much, but from personal experience, things that I can think of are breaking down information into like those schemas that I mentioned in the talk. I think that kind of providing analogies and different systems like that are really great ways to help students kind of get away from that overload so that they can focus on really obtaining information.
Yeah, and I will add to that, Sarah, thank you, that actually in the educational world, there has been a focus for some time on training teachers on this concept of overload and actually teaching strategies to minimize, not just for kids with impairments, but as ways to support learning in the population of children as a whole. So this is actually in the educational world already as something. Now, that doesn't mean it's always happening, but there is a focus in the teaching world on strategies to support or minimize, I should say, cognitive load. So it's interesting. But yeah, in terms of our neuropsychological assessments of children, these are recommendations we'd make specifically when we see kids who are presenting with this kind of a challenge. It really does have to do with structure and limiting how much we're asking them to do at once and attaching learning to these previous schemas that they may have, as Sarah said. So I think there are ways certainly to manage this, but it also requires us to understand that a child experiences this. So,
and Karen, just to add, related to that, there is a question, related to educational strategies. There is a question about how much homework should our teachers be assigned for kids with NF1. So that relates very much to what you were talking about.
Well, the literature shows the elementary school kids, regardless, shouldn't be getting any, whether they have NF1 or not, but we won't get into all that. But that's a good question. And again, and then we'll move on because I know we need to, but to that point, some of our recommendations are to adjust homework load and to do some other things around how much kids are having to do at one time. So we do make recommendations around homework as well.
Yeah.
Okay, I'll stop.
Yeah, I think we'll move on to the next speaker. I'm excited to present who she is. It's Dr. Young Howe. I know her. She's now an assistant professor at the University of Kentucky, but several years ago, she was a postdoc fellow in my group, and she continues to collaborate with us on some projects. Today, her talk is titled Predictors of Social Emotional Development in Children with NF1 and Plexiform Neurofibromas. Dr. Howe?
Hello, my name is Yang Hao. I'm an assistant professor at the University of Kentucky. Today, I'm going to present a study about predictors of social emotional development in children with neurofibromatosis type 1 and plexiform neurofibromas. First of all, I have low conflict of interest. Prior studies have demonstrated that children with NF1 tend to have more neurobehavioral problems such as cognitive function and social emotional deficits. However, most prior studies of neurobehavioral phenotype of NF1 used cross-sectional between group design. They often compare the neurobehavioral outcomes of NF1 children with a control group at a single time point. These studies cannot tell us how NF1 children's neurobehavioral function change across time and overlooked the within-group differences of NF1 children. A few available longitudinal studies focused on cognitive development, leaving social emotional development understudied. Therefore, the current study uses a longitudinal within-group design to address two research questions. How does social emotional functioning change across time in children with NF1? How do demographic and disease-related factors link to the initial level and change of social emotional functioning? Participants were 88 children with NF1 and PNs who were enrolled on a natural history protocol at the National Cancer Institute and completed neuropsychological assessment for at least one time during the ages of 6 to 18 years. They were supposed to complete 3 times of neuropsychological assessment every 3 years. 55% were male and 76% were white. Children's social emotional functioning were assessed by BASC-2, child-reported and parent-reported scales. Child-reported scales included 4 composite scores representing school disconnectedness, inattention, hyperactivity, internalizing problems, and personal adjustment. Parent-reported skills included the 3 composite scores, including externalizing problems, internalizing problems, and adaptive skills. We explored a wide range of potential predictors of social emotional development as listed here. First, let's look at some descriptive statistics of baseline social emotional functioning. We found that child-reported social emotional functioning is not significantly different from the normative sample versus parent-reported significantly more internalizing problems and fewer adaptive skills compared to the normative sample. To estimate how social emotional functioning changes across time and predictors of change, we used multi-level growth modeling. For average pattern of change, we did not find significant change in all social emotional functions, indicating similar social emotional development pace between the NF1 and the normative group. However, there are large individual differences. To illustrate this, let's look at this graph. In this graph, y-axis represents t-scores of parent-reported internalizing problems. X-axis represents time. Each blank line represents an individual trajectory. The red line represents the average pattern of change. This graph shows that there are considerable between individual variabilities in the initial levels of internalizing problems as well as the change pattern of internalizing problems across time. For example, we can see some increase and some decrease across time. For predictors of change, we thus vary across reporters and domains of social emotional functioning. In today's talk, I will focus on a few predictors of change emerged for both child-reported and parent-reported skills, including parental education, race, and visibility of tumor. I'd be happy to discuss other predictors in more details if interested. I plotted the change pattern for different levels of the predictors. This figure shows that children with higher parental education were more likely to experience decline in school disconnectedness, that is, improved school connectedness across time. This may be because parents with higher education can better help with children's school problems. We also found an increase in racial disparities in child-reported personal adjustment across time. White children's personal adjustment become better than ethnic minority children. This is consistent with the broader literature on racial differences in child well-being in the general population. However, we found different results for parent-reported child social emotional functioning. Parents with lower educational level tended to report improved child externalizing problems and adaptive skills across time. Compared to white parents, ethnic minority parents tended to report better child externalizing and internalizing problems and adaptive skills across time. These findings about parental education and racial differences in parent-reported social emotional functioning were different from studies of the general population. It is possible that parents with lower education and ethnic minority parents perceived better child social emotional function across time because parents adjusted their expectations and are more accepting of their children with NF1 across time. But future studies are needed to further investigate what led to such differences in this particular population. I would also welcome your input on this. Regarding visibility of tumors, we found that those with more visible tumors and baseline were more likely to experience improved school connectedness and adaptive skills across time. In other words, it appears that social emotional functioning improved for those started with more visible tumors, whereas become worse for those started with less visible tumors across time. These results are likely due to two potential reasons. First, they are partly reflect regression to mean because those with greater visibility of tumors and baseline had more initial social emotional functioning problems, and initial levels were negatively associated with change over time. Second, visibility of tumors increased across time, especially for those started with mild visibility. Thus, increase of social emotional functioning problems for those with mild visibility may be associated with increase of tumor visibility across time. Overall, our results suggest that social emotional deficits seem to be less severe in F1 children compared to cognitive deficits as shown in prior studies. Our study particularly highlights substantial within-group variability of social emotional development among F1 children. First, we found that patterns of social emotional development vary across reporters and subdomains of social emotional outcomes, indicating the need to assess social emotional functioning comprehensively using a multi-informant design. Second, we found various demographic and disease-related factors account for the within-group variabilities in social emotional development. That said, before any firm conclusion can be drawn, we need more future studies with larger sample size and comprehensive investigation of potential mechanisms underlying the link between demographic and disease-related factors to social emotional development. Finally, I'd like to give my sincere thanks to the NF1 clinical research team and NCI, especially Pam, Stacy, Marianne, and Terry, who provide lots of support in the preparation of this paper and presentation. And I also want to thank the children and families participating in this study as well as these funding resources. Finally, I want to thank you for listening, and I would welcome any questions and comments. Thank you.
Great talk. Thanks, Dr. Howe. Again, it's great to see the longitudinal work so we can learn more about the trajectories of these difficulties that children with NF1 have. We do have one question. Dr. Klein-Tasman says, it's great to see longitudinal work and the emphasis on variability is so very important. Given the wide age range of the participants, what happens if the x-axis reflects the age at assessment rather than the time point?
That's a great question. Yeah, I wish we would have, have larger sample who have similar age and assessed multiple times over time, so we could really map how the social emotional development across different ages. But for this sample, we are not able to do that because, they are assessed every 3 years, and there's a wide age. There's a wide age range, as you said. But in the analysis, I did look at whether the age would moderate, would affect how they change across time a lot. And I didn't find the change pattern vary across age here. So that means what I have presented are similar across different age groups.
Pam, I have a couple, I don't see any other questions in the chat yet here, but if I could ask a couple things. So one's, again, I guess more of a comment. So I think in your future research, what would be really interesting is to expand the age range of this sample, because when we did the survey of individuals with NF1, the adults with NF1 who were reporting on their own experiences really did highlight much more experience with internalizing symptoms than the children or the parents of children with NF1. So I suspect that you'd maybe see something different if you included adults into this sample and what that trajectory continues to look like. So I guess that was just one comment. But then the other thing I was going to say is, when you have some of these differences, but the average scores really are not falling into these clinical ranges, like on the BASC, et cetera. So I'm wondering if you pulled out, I'm sure there are kids who fall into that range. I wondered if you pulled those out and looked at their trajectories in particular, because I would think that maybe that would be a different pattern than those that are not kind of having clinically significant ratings.
Yeah, that's a great suggestion. Thank you. So we can show that whether the initial levels, like whether they are started with worse or better, is related to the change patterns. Yeah, indeed, but they are actually negatively associated, which means if they start with better, they are more likely to decline. If they start with worse, they are more likely to be stable, which is not surprising.
Oh, okay.
And
so the kids that are having problems aren't really getting better. And then is that what you mean?
So the kids having problems, in some cases, like in most of these cases, they are, in some cases, they're getting better. That varies. For the child-reported, child-reported school correctness and child-reported personal adjustment, they tend to become better for those who start with problems.
And then I have one question. You said you looked at different NF complications. Did you look at how ADHD might impact social emotional development across time?
I didn't analyze whether the difference between those who have ADHD versus who haven't. However, I did look at whether they were diagnosed with psychiatric disorders that included ADHD and other types of psychiatric disorders. I found that the group who reported that they have been diagnosed with psychiatric disorders, they only have higher initial levels of internalizing problems, but the change pattern across time are the same. Yeah.
Okay. And there's one last question we have, so we'll try to squeeze that in. Do you have data to isolate economic factors, which are often intertwined with parent education and ethnicity factors as potential contributors?
Economic factors.
Like SEF.
The family, family income, I guess, because primary education is often used as one indicator of socioeconomic status. I guess it means something like income, right? So yeah, definitely the income, education, and ethnicity, they all intervened together. And actually, I have analyzed in some model. I analyzed when I analyzed the ethnicity and primary education in the same model, the effect of I think some effect of primary education may become more evident, and in some cases, the effect of ethnicity may become more evident. So yeah, definitely they have shared variance, and when you enter the same model, maybe a lot of unique predictors. Yeah.
Okay. Great. Thank you so much.
Okay. Well, yeah. Thank you. I guess I'll take over so you don't have to introduce yourself, Pam. So I am very pleased to introduce my good friend and colleague, Dr. Pam Walters from the NCI, who will be presenting on perspectives of adults with neurofibromatosis regarding the design of psychosocial trials. And this is a result from an anonymous survey online.
Hello, I'm Pam Walters from the National Cancer Institute, and I have no disclosures to report. Today I will be talking about the results of an anonymous online survey that assessed the perspectives of adults with neurofibromatosis about the impact of NF on their daily functioning, as well as their thoughts about participating in psychosocial clinical trials. Psychosocial concerns are common in adults with neurofibromatosis and may include difficulties coping with clinical symptoms such as pain and fatigue, mental health problems such as anxiety and depression, and impairments in social functioning. Thus, clinical trials that evaluate psychosocial interventions, which are behavioral programs that teach coping skills to better manage symptoms and stress, may improve general well-being and quality of life and be helpful for adults with NF. However, there are limited psychosocial clinical trials conducted in NF. There are just a few published interventions, which include a mind-body program for adults with NF done through video conferencing, and acceptance and commitment therapy for adolescents and young adults with NF1 and chronic pain. Therefore, it is essential to develop and evaluate psychosocial interventions to meet the needs of individuals with NF. Engaging patients in the process of designing psychosocial clinical trials is beneficial for several reasons. Their input can help identify new and relevant areas of research, design targeted procedures, and select the most appropriate clinical outcomes, and improve recruitment, enrollment, and retention by developing meaningful and feasible studies. Thus, the primary aim of this study was to collect information directly from adults with NF about their psychosocial functioning and preferences regarding psychosocial interventions to inform clinical trial design. A multidisciplinary group of clinical researchers and patient representatives from the RAINS International Collaboration developed an anonymous survey that assessed demographic characteristics, NF complications and their impact on daily life, as well as self-reported psychosocial concerns and perspectives on psychosocial trial design. The survey was distributed online last summer by the NF Registry and regional NF organizations in the United States to adults with NF1, NF2, and schwannomatosis. In terms of the results, we had 630 respondents for a 71% response rate, and the mean age was 45 years. The majority of participants were female, white, not Hispanic or Latinx, and U.S. residents, and adults with all three types of NF responded. Next, I will review the results on the survey questions about their self-reported psychosocial functioning. This graph shows that very high percentages, from about 83 to 93% of individuals with the different types of NF combined, reported some degree of impact of their NF symptoms on their physical, social, and emotional well-being, with over one-third rating the impact from pretty much to a lot. Regarding mental health concerns, approximately 52% reported having been diagnosed with a mental health problem, such as anxiety or depression, while an additional 27% who were not diagnosed reported that they thought that they had mental health difficulties. Of those adults who were diagnosed, about 72% reported taking medicine for a mental health problem, and a little over half reported seeing a mental health professional recently. In terms of psychosocial difficulties during childhood, the majority of adults reported having learning, mood, or social interaction difficulties when growing up. Of the 54% of participants with learning difficulties, only about half reported receiving interventions or assistance for these problems in school. Support services for the other psychosocial problems was even less. Only 21% of those endorsing mood difficulties and only about 10% of those endorsing social interaction difficulties during childhood reported receiving intervention services for these problems. When comparing across groups based on NF diagnosis, individuals with NF1 were significantly more likely to report having learning, social, and mood difficulties during childhood compared to individuals with NF2 or schwannomatosis. However, there was no difference among the three types of NF in percent of individuals reporting mental health diagnoses or mental health difficulties if they were not diagnosed. Finally, over half of adults reported that their mental health difficulties and their NF symptoms had a moderate to severe impact on their daily life, thus highlighting the challenges that adults with NF face every day. Even though many respondents experience NF symptoms and mental health problems, only about 6% endorsed participating in a drug trial, and only about 7% endorsed participating in a psychosocial trial, so it appears that there is a great need for more clinical trials for adults with NF. Now I will summarize the participants' preferences regarding psychosocial trials. In asking about their willingness to participate in psychosocial randomized controlled trials, or RCTs, about 68% responded that they would be willing to participate if the trial targeted an important area of interest for them, and a similar amount were willing even if there was a short waiting period before getting the intervention. Interestingly, the majority of respondents also said that they would be willing to participate in a psychosocial RCT even if they might not get the intervention or if they did not know which intervention they would be getting. We found no significant group differences in willingness to participate in psychosocial trials across the 3 diagnoses based on the severity of NF symptom impact, or by age, sex, race, distance from the nearest NF clinic, or employment status. For another question, we asked respondents to check the types of psychosocial trials that they would be interested to participate in. This graph shows that the top selected psychosocial trial targets were helping to cope with anxiety, daily stress, depression, NF physical difficulties and pain, and helping to develop a healthier lifestyle and increase social interactions. In comparing respondents with different types of NF by their preference for psychosocial trial targets, adults with schwannomatosis were significantly more likely to be interested in trials focused on helping them cope with pain compared to those with NF1 or NF2. In addition, adults with NF2 were significantly more likely to prefer psychosocial trials focused on coping with NF physical difficulties compared to individuals with NF1. However, there were no significant differences between NF types on any of the other trial targets, which suggests that it may be reasonable to explore combining adults with different NF diagnoses in a single psychosocial trial when it is targeting a mutual area of interest. We also asked respondents to select their main reasons for participating in a psychosocial trial, and the top choices were to improve health and well-being, to help others with NF based on study results and what was learned, to meet and be cared for by NF experts, and to try new interventions for NF symptoms. The top barriers to participating in psychosocial trials were distance to the clinic or research site, with only about half living within an hour drive from an NF clinic, costs, time away from school or work, and concerns about the privacy of their information. In examining the different types of programs and delivery of psychosocial trials, about half preferred individual sessions led by a clinician or a combination of group and individual sessions led by a clinician. 64% preferred a combination of 1 to 2 in-person sessions, with most delivered virtually, while 44% preferred doing the entire program virtually from home. And to help plan specific psychosocial trials, most participants preferred completing surveys, interviews, and focus groups, primarily conducted virtually. When asked what clinical outcomes would be important to assess in psychosocial clinical trials, the choices that respondents selected most often were reduced symptoms of anxiety, depression, and stress, improved coping skills, and better self-esteem and overall quality of life. Regarding the preferred method of administration for patient-reported outcomes, the majority preferred electronic questionnaires completed at home or clinic, while fewer preferred paper and pencil measures completed at home or in clinic. Finally, 84% of participants responded that it was important for them to receive the results of clinical trials, with the most preferring an email or letter summarizing the results. In conclusion, this is the largest survey of adults with NF assessing psychological well-being and preferences about psychosocial trials. Results indicated a high prevalence of reported mental health difficulties and moderate to severe NF symptom impact on daily life, which indicates the need for mental health screenings, referrals for support services, and the development of psychosocial trials. There was a high degree of willingness to participate in psychosocial intervention trials across NF diagnoses. Finally, it is important to incorporate patient preferences to help design the most meaningful and feasible clinical trials. For future directions, there clearly is a high need and interest for psychosocial trials, so it is important to address barriers to participation, engage specialized efforts to increase diversity of survey and trial participants, design and implement interventions for children with NF so we can start treating psychosocial difficulties earlier, develop electronic patient-reported outcome measures to be completed remotely from home, and to use the current results and engage patients further to develop future psychosocial trials focusing mostly on developing virtual interventions. I'd like to finish by acknowledging my collaborators on this project, who are all listed here, from the NCI, Massachusetts General Hospital, and the Children's Hospital of Los Angeles, and the RAINS patient representatives. And I also want to give special thanks to the NF organizations that helped distribute the online survey and the adults who took the time and effort to complete the survey. Thank you for your attention.
Thanks, Pam. Of course, I have questions or thoughts too, and I'll look for questions from the audience here. It's interesting because this matches with the survey results in a lot of ways that we got when we had some adults, obviously, with NF1 in our sample as well. Did you ask them about whether they had ever been talked to about research? One of the things that came out of our survey is that people said they were very interested in participating in this type of research and cognitive research. But then one of our questions was about whether they had really heard about research much. And we were surprised to see that there was this discrepancy between their desire and our ability as scientists and researchers to be letting people know that these studies exist. Is that something you think is going on here?
Yeah, that's possible. We didn't analyze it for this particular study, and we're still working on that. There were some questions about how they found out about different studies, whether it was through foundations or clinicaltrials.gov. We didn't look at that yet, but I think it is important to reach out to as many ways as possible to different, and even in the communities, to really try and get the most participants that we can. But that's definitely something that we should, we'll analyze that and include that when we prepare the manuscript. So.
Yeah, great. Okay, there's a couple questions here. So from an anonymous person, thanks for the great presentation, Pam. Wondering about gender differences in report of mental health issues and preferences. I mean, your sample was pretty highly female dominant, but they're wondering if you know anything about gender.
Yeah, we didn't have any differences between gender in their willingness to participate. In terms of mental health difficulties and stress, we did find that females wanted, again, I was focusing more on the type of trials. They wanted more trials that related to coping with stress. It makes sense. And also this study was done during COVID last summer. We did ask them to try and think, of their difficulties unrelated to that. But we did have some questions on COVID, and females were much more likely to have stress related to COVID as well. So we'll begin to tease that out. But you're right, the females did have more stress than the males.
Interesting. Yeah, the COVID factor is going to be important in all of our research, right, as we go along. Dr. Klein-Tasman, our good friend, says, yes, we need more intervention work. And then a comment she has that there seems that we have, as a field, have a good deal of work to do about the emergence of anxiety. So many adults with anxiety challenges, while Young's talk would suggest these aren't that evident quite yet during childhood. So really, I guess, learning when these things really start to emerge so we can address these issues.
And you brought that up in one of your comments, Karen, like really to keep going, because the adults may be more apt to then really endorse that they have those difficulties. We obviously want that to happen earlier so we can help children. And it's interesting because patient representatives that helped develop this tool and the survey, really, they're the ones that pushed wanting those questions about, when did these difficulties begin and what help did you get? Because again, we need to focus on getting help and interventions and screening and, beginning treatment earlier in childhood to help that. So to prevent difficulties later.
Yeah. Well, I know we've only got a few minutes left. I thought maybe I'd say a couple summary things and Pam then let you say a few things and wrap it up. But first of all, thank you to all the speakers. All these talks were very interesting. And there was more of a maybe lifespan theme than we even thought of at the beginning. And I really like all this work that's focusing on trajectories and patterns of performance over time. That's obviously hard data to get because it takes many, many years to figure those things out. I think it became clear to me that things around transition and us really thinking as clinicians and researchers about thinking about that much, much earlier in these kids' lives and much more about education of their disease. And, I think that kids know in some ways more than families think they do. But on the other hand, then there's not a lot of discussion sometimes because of fears about kids being afraid of some of the factors related to their condition. So I think we, as professionals, can do a good job of helping families with those discussions. And then, obviously the other thing that stands out to me is just these psychological or psychosocial issues. I mean, I think this has not been a focus of a lot of research in NF until really recently, but I think there's a lot of work to do. And we're hearing from individuals with NF, in childhood, adolescence, and adulthood in particular, that this is important to them and that they suffer with some of these deficits. So, Pam, I'll turn it over to you for some final thoughts if you have any.
Whatever's left, right?
Whatever's left.
Yeah, I did want to say that I really liked to see that a lot of research is going on in a lot of different domains. The motor, adaptive functioning, which is a new area in transition, which is so important, in addition to cognitive and more also on the social emotional. And it just shows the importance of looking at these areas and identifying the concerns early, and then getting them in services, whether it be an intervention that is only for NF or services from their school or their home, mental health professionals, across the board. Those all can be helpful to this patient population.
Well, look at us ending right on time. Thank you again to everybody for participating.
Right. Thank you. Bye-bye, everybody.